Best OB-GYN in the area, shoot. And people are like, bam, bam, bam. And I'm reading the names of the doctors, and I'm like, how are you going to choose? Who are you going to choose? This doctor, he is proud to say C-section is the best way to have a baby. Even if they do prefer to get in some point an epidural, they still need a doula.
So explain that to me. Hey guys, welcome back to the podcast. My name is Dr. Bitran. I'm here with Diana. She's a doula who graciously shared her time with me today.
Thank you.
Today we're going to go into a few things, what you do as a doula. We're going to talk about birth plans, and we're going to talk about what beautiful things you do for your clients to give them the experience that you want.
Good.
Amazing. Stay tuned for the rest of the episode, because towards the end she's going to show me some movements and circuits to do to help get the baby down. So, Diana, tell me about yourself.
Okay, so my name is Diana, and I am a doula for the last 19 years, almost 20 years. I first became a hypnobirthing educator because actually I was a hypnotist before.
Really?
Yes. This is how I was a holistic therapist, and a colleague came and said, you know what you're supposed to be doing? You're supposed to be helping women having babies with hypnosis.
Incredible.
And my brain was like, oh my God. So I started looking for courses. I did one that I didn't like, and then I actually found hypnobirthing. And since then, I am educating new parents, and also not so new, second time, third time parents, to actually be prepared, be ready to have a beautiful birth, trusting themselves, trusting the body, trusting the process, and putting fears. I invite them to put the fears here in my space. They can come and take them back if they want, but yeah.
That's very true and very fair as well, because now we find out you get pregnant, people call my office 4 weeks, 2 days pregnant, going, I'm pregnant. Yeah. And we do all these things, and yes, there are some scary things that can happen with birth, but the anxiety now is to another level. Sometimes we try to get so much information to help people, and then a lot of times it backfires and they get completely like analysis by paralysis, complete.
Absolutely. Yeah, we need to remember all the time that usually, especially women, they grow up many times with the story of their own birth. And the stories sometimes are terrible, and I almost died, and it's so painful, and blah, blah, all of those stories that we grow up, that when it comes to us to have the babies, we start actually, you know.
Yes, you get a little in your head sometimes.
Yeah. Sometimes more than a little, but yes.
Definitely. I usually say, at least in our practice, our job as doctors is to create a safety net to make sure those things don't happen. And ideally, your body should do everything on its own.
Absolutely.
I tell my patients, I'm really lazy. I don't want to work. I want to show up, you do all the work, and then tell me, Doc, you're amazing, and I get all the credit.
Absolutely. You know how we say in hypnobirthing?
Tell me.
You don't supposed to be delivering the baby.
Correct.
You are not a UPS guy.
Correct.
You're supposed to be receiving the baby.
Very fair. And I tell my patients as well, is if I delivered all the babies, I would be exhausted.
Absolutely.
To have all those babies go through me, I'm like, I'm
no.
not the one doing it, you are.
By the way, she's not delivering too, she's
Correct.
birthing.
She's birthing.
Yes.
Correct. You're
Thank
right.
you.
You're right.
Yeah.
So, great. It sounds like you have such an amazing past doing this, starting from a time of hypnosis. Tell me, was there any specific moments or experiences that really hit you, that made you go through with this? Like, how was your first birth experience?
Oh yes, actually I'm one of the women that grew up with a beautiful story of my birth, the day I was born. I'm sorry, I touched that.
No, it's fine.
And my mother, until today, she will say, I came to the doctor, I thought I might be in labor, and he checked and he said, run, 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 baby's coming. She almost didn't make it to the birthing room, I was out.
Wow.
And that's the story I grew up with. So when I actually was pregnant with my first daughter, today she's 37.
Wow.
I said, of course, I'm talking about kind of the beginning of epidurals in the birthing room. I said, I will not need the epidural because I'm coming. They will check me and they will say, run, 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 baby's coming, and I will have the baby. So it was not like that, actually. Actually, I came to the hospital. I had my kids, the three of them in Israel. I came to the hospital and they checked me. I was 2 to 3 centimeters. They sent me to walk around. I came back 1 hour later as they asked me. And they checked me. I believe I was 2 to 3 centimeters still, but they admitted me. And without even telling me, they started the dripping of Pitocin. 30 minutes later, I was shouting like crazy, bring me something. So I believe around 6 months later, I was like, what happened? Why? Why it didn't work the way I was, expecting? So I start asking questions. My second baby, he's 34 now. I came to the hospital. I was kind of leaking a little bit. 1 hour later, I was holding my baby.
Wow.
Crazy birth, but 1 hour. And 4 years later, I was there again with my today 30 years old baby. And it was an amazing, beautiful, unmedicated, no interventions, 6 hours birth. And when I left the hospital, I told my husband, I want to be a midwife because I had an amazing midwife in the hospital. But with 3 little kids, didn't make it. So when this guy told me, you're supposed to be helping women having babies with hypnosis, everything actually...
It hit you and it...
Yeah, I knew. And the more I do it, the more I believe it was what I was supposed to be doing, and I wish we had more doulas.
We're working on it, and you're working on it. You're
Absolutely.
doing a great job. And on our end, on the doctor's side, we see both, and there's a huge, almost a stigma. There's even hospitals around here that won't even let doulas into the hospital, and it's because the over-medicalization, like you told me with your first birth, there's been a huge pushback in the community away from doctors.
Yeah.
So from there, sometimes there's a distrust in the system. So, and then because of that, the doctors push back, and there's like sometimes in some places, not a good connection between the doctors and the doulas. And that needs to be fixed, because specifically patients that want more of a physiological birth process, they should be empowered.
Absolutely.
Like going back to my safety net analogy, like you need the safety net, but then from there, you need to let people be. Our job is to intervene when Mother Nature is not so nice. Does that make sense? Or in this case, if they desire pain control, if that is something that they want. And another thing you said there is, you told me before we started, you're waiting for a birth. It can be at any moment in time.
Any moment.
It could be at 3 in the morning. To do what we do, anyone on the obstetric side and in labor and delivery, we have to be willing to be paid somewhat emotionally. Because
Absolutely.
For us to get up and go at 3 in the morning, we have to have a calling in our heart to tell us, I really don't want to get up right now, but when you leave, there's a smile on your face and your soul is somewhere.
You know what, I always say, first of all, when some births are, I don't need to tell you, 20 hours, 40 hours, 5 hours, and we never know. We never know. So the feeling I have once baby is coming, even maybe after 20 hours birth, it's amazing. Adrenaline makes you smile anyway. So it's I always say it's the best job with the worst hours.
Yes, for sure, for sure.
Also for you.
I don't know how my father is 71 years old and still doing this.
Your father is something else.
Yes.
You know that. I don't need to. And I'm not the only doula thinking. I think most of the doulas will say, oh yeah, Dr. Bitran. Yeah.
Yes. For sure.
We like working with Dr. Bitran, and now with son.
Yes. I have to say also, I'm happy with our whole group. When I started, first of all, on a personal note, those were very big shoes to fill. And I'm not him, but I'm myself, and I'm so blessed that I get to work with him. But also Dr. Tendler and Dr. Rivera, I'm so grateful to be working with them because we practice in the same line.
Yeah.
I wanted to transition a little bit from now. There's an amazing personal story to when you get someone here that is desiring a physiological birth, what preparation do you do with them during labor and then going into labor and then after?
Okay. First of all, I will express my desire and preference for them to take the hypnobirthing class. I make clear that I am not the only hypnobirthing educator here, so I'm not selling myself, I'm trying to sell hypnobirthing. I do believe it's an amazing way to go. But then we will be working together. We are going to be meeting at least twice in their place. They come here, answering any questions. It's much easier for them to reach out to the doula than to call the doctor, right?
I'm not sure about our patients, but generally I get that.
I'm not sure either.
Yes,
but you know, they just need to text me, and exactly 5 seconds later, I will be answered. And if I'm busy, I'm going to ask them, is this important? Is this, you need me now? So the idea is to make sure they, as I said before, they trust their body, they trust the process, they know this is it, and they are designed to do it. They can do it. We need usually partner to be part of the equation, very important. We need a partner that is also trusting her body and the process. So it's about kind of a dialogue between my client and myself, where I will answer any question. If I don't know the answer, I have no problem telling, hey, let me check. I don't know.
And that is a sign of a good healthcare practitioner in general, on any level, is to know, hey, this is my realm of practice, this is how I can help you, and to leave your ego at the door and say, hey, this is my scope, I don't know, let's figure this out together. Absolutely,
yes. There is something else that maybe there is when doctors and doulas might, if somebody calls me, hey Diana, I have a terrible headache. Can I take Tylenol? I know she can, usually, but my answer will be and must be, call the doctor.
For sure. And what's funny too is I usually ask, why does your head hurt? Because Tylenol doesn't always help. There's many reasons in pregnancy that can cause that. Do something, I don't know, if I didn't become an OB-GYN, I think I would have went into physical therapy. I sometimes...
you can do both. I trust you.
Have some patients in the office, sometimes I'll just lay them back and I'll put some pressure, lay them back and put pressure on their occipital. So there's some stuff, there's some coping things that are so helpful, especially with the changes in pregnancy, the way your body changes, the way you stand, the way your head moves, sometimes can cause a lot of tension in the neck that can cause a lot of headaches, along with just the hormones, and that's inevitable.
Absolutely, yeah.
But great. So what are specific things that, if you had 3 things that you would teach someone, that if they're watching right now and let's say they didn't have access to a doula, what would you teach them to do to deal with non-pharmacological pain?
Breathing techniques.
And like which one do you normally do?
I love what we call the surge breathing, which is inhaling very slowly and expanding the abdomen, so we are...
So if I was one of your clients, walk me through it. Okay,
so take a deep breath, slow and deep through your nose, perfect. And while you are inhaling, expand your belly. Like show off, show everybody your belly. You can visualize like a balloon, you can visualize like, exactly, put your hand, that's perfect, that's the way. The slowest you can do it, the better it is. So you are inhaling, expanding your belly, and then exhaling, and your belly goes up. And that's it through all the surge, from the moment it starts until the moment it ends. So we are getting her to breathe, to expand so the uterus can do the work, to focus in something, not in any other thing, and to have a rhythm. During labor, the rhythm is so important to get, to keep a rhythm of breathing, of movements, of everything.
And I will tell you, I'll walk into a room sometimes and I'll see them with their doula, and I can tell almost instantly if that patient's going to be successful without an epidural or not, based on their ability to breathe.
Yeah.
It is so important to be able to allow that parasympathetic, that rest and digest
Absolutely.
motion to allow your baby to pass down it.
Yeah.
It's just funny because we're talking about pain control. Epidurals, people, believe it or not, they dilate 30 minutes faster. They push 7 minutes longer. The reason why is because they're able to get the abdomen to relax. So the breathing, I think, like you're saying, is such an important...
So if we are talking about epidurals, I need to recognize that sometimes, especially if she's, let's say, 7 centimeters for the last 5 hours, she gets the epidural, boom, she's there. I don't like to recognize that.
But we have to
But we need to recognize that.
And we need to also meet people where they are.
Yeah.
And the reason why, I'm not even saying that, I don't think there's an issue recognizing it, because you are trying to get that person to naturally do what the epidural does, which is to relax their diaphragm down. I've had that happen so many times because you see people holding tight, which is, I think if someone wants a physiological birth, it's so important that they do the training, and you need a doula beforehand. On my side, the way I see it and I counsel patients is we are made to run marathons. If I run a block, I'm throwing up. We're made to have physiological births. But if it's 5 degrees too hot, 5 degrees too cold, I'm cranky. So I'm not saying you can't do it, but I think we are so far from what nature has given us naturally that we need to do the work to get back if you want that experience. If I put you out there and you didn't have access to an epidural or in a hospital, your body would do it anyways.
I can tell you from home birth, where the pregnant woman, the laboring woman, it's not an option. Epidural is not an option. They are birthing babies.
Correct.
Beautifully. So I always say, we women, we live in diet, right? So if you ask me to have some chocolate cake, I believe after the third time you ask me, I will. But if I'm home and there is no chocolate cake, I don't even think about chocolate cake.
I still think about the chocolate cake. But, no, I completely hear you with that. And that's also why I think I have some patients that tell me, I don't want an epidural. And I go, okay, how are you planning on not to get an epidural? Because that is very important. I think they need the training, but also they need someone to come in with, they need someone to train them. They need someone to labor with them at home. Because what happens is this classic mom, they come in, I'm contracting every 3 minutes, and they examine her and she's 2 centimeters. And I go, listen, I can give you an epidural or induce you, or go home. Go home. I just can't keep you there for 3 days with a contraction every 30 minutes. So they need to, the training is so key.
It's very important. I think it's important mostly for them to hear that they can do it. Because in the regular basis, they will hear the other option. You cannot do it. When they come here,
they get empowered.
Exactly.
Just funny, on our end, it's a double-edged sword because they don't understand what can go wrong. And that's why I think the relationship between patient and doctor, and also patient and doula, but in this case, doula and doctor, that if I make a recommendation, because you trust us as doctors, that you recognize that and you trust our decision. Because what happens is they get empowered, which is beautiful, but then their water's broken for 24 hours and they're not accepting Pitocin. And I tell them, what is our big goal here? Because I think people lose perspective is, for us, and we'll talk about practice models in a second, the most important thing over anything is a healthy mom, healthy baby. And I think everyone agrees on this, but I think sometimes they get lost in the woods and not disoriented on what's really important, is a healthy mom, healthy baby above all else. Then from there, ideally a vaginal delivery. And then from there, whatever experience you want. And it's important to know because if you look historically, the maternal death rate was 1 in 8. And I'm not saying, because we're going to talk about home births, I'm not saying in a home birth. I'm saying before there's any attendance, like before there was people watching you. And that's also important when you're choosing a healthcare practitioner, which we should also touch on. You need to know who they are, you need to do your due diligence, and you need to have a sense of trust, especially if you're not in the hospital, because you are trusting someone to make a decision with your life and with a delay in care, meaning because you're not where someone can do something. So
I agree. I do believe healthy mommy, healthy baby, this is what everybody wants. I do believe that that experience she will remember for the rest of her life.
And that is why we're both blessed to be a part of their
Exactly. So we need to make sure that when she goes back, she can smile.
Yes. And that works in 2 ways. Number one, them being empowered, but also expectation management. And
Yes.
that is, and that goes into the whole, from the beginning. Where we're planning on doing this, what experience we want, understanding things can go wrong, but you should not be your plan A. Your plan A is, we're marrying something beautiful here, which is the tradition of literally why we're here. Mom having mom to where we are now.
Yeah.
To something scary, like traditionally a 1 in 8 death rate, which is terrifying. So
Still, we have a very high rate in the States.
yes, it's because we are very unhealthy. And the other thing I want to talk about too is when we're talking about a practice care system, you have to understand where we're coming from. You didn't have your babies in the States, and different countries have different tolerances for different things. In America, it is life or death above health,
Yeah.
above anything else. And as a doctor, and I'm saying this because these are questions I think you should ask your doctor, is what their limits are and are you okay with that? And if not, go somewhere else or accept what they're doing. But your care will be so much better if as a team everyone's on the same page. So when we come from a place of life above all else, it's also, remember, my wife's a lawyer. It's a very litigious society. We will not tolerate one bad baby. And that is the core above anything else, even if it means doing a C-section. That is our standard, our practice, and our markers. And when people come in and we're making these decisions, that is what it's based off of. There's other countries, there's other cultures that are there's more acceptance for things going wrong. And there's a different relationship with life and death and the birthing process. So these are, I think, questions people need to ask themselves, and I really, really, really don't think there's a right or wrong answer here. It's just, I think, requires some self-reflection and some knowledge of yourself before you make it. And when
I agree with everything. I do believe, back to the mother or to the couple deciding, looking for a caregiver, if it's a OB-GYN or a midwife.
Correct.
In my opinion, is both very important. To ask the right questions. You know, sometimes really sometimes, because I forgot how to work with Facebook. I don't even remember the name. I open and there is a question. Best OB-GYN in the area, shoot. And people are like, bam, bam, bam. And I'm reading the names of the doctors and I'm like, how are you going to choose? Who are you going to choose? This doctor, he is proud to say C-section is the best way to have a baby. So important for these couples to find the practice that is aligned with their own. Because if, let's say I'm a new mother, I come to you and say, hey doc, I want to have an unmedicated birth. You have 2 ways to answer. The first one will be,
I'll just answer how I answer, and then you can tell me if it's right or wrong.
okay.
I tell people, that is beautiful, and we do the best we can to fully support you.
Beautiful, thank you. How about if I tell you that some doctors will say, we'll see?
Oh, okay. Let me put more caveats also. You're right, but then it's also what you say. I say we can fully support you, but there's limits to what I'm able to offer you. Number one, I think that's amazing, but if you're going to be successful, we need to have a good care team. And I strongly, strongly recommend getting a good doula who you trust. That's the first thing. The second thing, as basically what I talked about before, is our number one priority here over your experience is the health of you and your baby. So our practice has certain parameters that we have to stick to that may have us potentially shift course. What are those things? For example, you may want a natural birth, but let's say you're above 40. Let's say you're 45 years old, this is an IVF baby. We know that there's risk going past your due dates for preeclampsia. I cannot counsel that patient the same way I could a 25-year-old patient. The patient is hypertensive, the same thing. If they're going past 41 weeks and now those risks go higher, as a practice, we decided we don't want to take those risks because our main way of practicing is risk mitigation, is to do nothing, but we have specific parameters that we hold to. And that is different for each practice. You may tell me, Doc, that's really nice, but I believe in 42 weeks. Doc, that's really nice, I don't care if my blood pressure is high. But my point is then we may not be the right providers for you. You may say, I understand that and I'd rather go a different route, and that's acceptable, but it's our job to give medical advice, and we still need to set the parameters of our practice.
Absolutely. But the difference is all your explanations are very valid and important, but your approach is yes, of course. If everything is perfect,
yes,
yes, of course.
It's yes until proven no.
Versus
yes,
a
versus
doctor
no,
that will
yeah.
like even make fun of.
Which is horrible.
So be aligned. Make sure your doctor is aligned. Hey doc, I want to have a non-medicated birth. How do you feel about it? Mm-hmm. And then I always tell them, look at them. It's not only what they're saying, but what they're saying.
Yes.
And if they're saying, we will see, run. Mm-hmm. Go and look for the right doctor for you.
Correct.
Because
or midwife or
midwife.
center. And that goes into it because we talked about those values before is, for the record, if you look at the European data, there are worse outcomes, but those outcome numbers are different for everyone. If I told you, hey, there's a huge range of numbers, 1 in 500 of those births that don't go well. We do more than 700 births a year, which is huge. For one person, let's say 1 in 500, it might be different for different practices. It might be a little less, it might be closer to 1 in 1,000, depending on how they're choosing their patients and how they're doing it. But some people really want to deliver at home in a bathtub, and that's okay. They just need to be educated on that increased risk. If it's 1 in 500, it's a lot better than 1 in 8, right, of a bad outcome. But they should just choose those paths first, and they should go through those experiences if that is what they want. And that goes with, if you choose us, I think I sleep very well at night with the balance that our practice has. The way I practice, the way my father practices, is Dr. Taylor and Rivera practice. I think we're all a little different, but we really do the best we can to support people, but again, to those limits.
Yeah. Yeah. If we are aware of the limits, we can work from that together.
Yes.
And that's important.
And it's something we should do in the beginning.
Yeah.
So if we're going there, this is something, by the way, I don't read birth plans, but I recommend everyone do
to have one,
because I think they need to know what they want.
Yes.
So let's go into that next.
Good.
How do you approach, I guess we'll call them birth preferences now. Yeah. How do you approach birth preferences with your patients?
So for me, the birth preference, first of all, I know your practice prefer not to have them, but when somebody tells me, let's say we are working the hypnobirthing class about the birth preferences, and I have Dr. Bitran, I say, okay, they don't like birth preferences, but if everything is okay, they will do whatever you want.
That's exactly what I tell them. I'm like, you're doing the hypnobirthing thing, cool, great.
So this is what I'm telling them too. Regarding you guys, again, I'm sorry. This is not a advertising.
No, it's not. But there's a variety of way of practicing. And by the way, there's more people that are a lot more lenient than we are around this area as well. Yeah. So what I'm saying is, there's many good people around.
Absolutely.
Just do your due diligence beforehand.
So for me, it's kind of a educational tool. Mm-hmm. The birthing preferences, because we go one by one, especially with my clients, my doula clients. We go one by one and I explain to them what that means. For instance, IV head lock. For many years, everyone was with IV, with the dripping of fluids, walking around with that pole. You have no idea how uncomfortable it is. Maybe you do have an idea. It's uncomfortable. So, okay, that means that you can ask to do the IV because you're in the hospital. You don't want an IV, stay home.
Correct. Yes, so you just need, and it could be covered, it could be fine.
Exactly. So we talk about that. Let's say the intermittent monitor. So I let them know. Usually most of hospitals in South Florida, it's 20 minutes in, 40 minutes off, which means you have 40 minutes to walk around.
Yeah, and then the other thing, it doesn't always work. I prefer to continuous monitor, but they have a Novi, which is wireless.
Exactly.
That even works in the shower.
Yes.
I've had patients in the shower, which is phenomenal that we can even offer that.
Beautiful. Then, so I go one by one and I explain what that means. And sometimes people are like, what? They didn't know about
Correct.
so many things. When they get there, the triage, so I use it as an educational tool. For some doctors, I tell them, take this to the doctor. If it's a practice with 10 doctors, make sure everybody is part of that and take 2 copies to the hospital. Why 2 copies? Just in case. You never know.
Yeah. I can say in general, luckily, I don't care which practice you see in Mount Sinai, the nurses are absolutely phenomenal.
Yeah, I like the nurses.
They're very willing to work with people and they really, really support
I
physiological
have
birth.
nothing but good words, really.
Yeah, I'm very lucky because
Yes.
they make me look really good.
Absolutely.
They do all the work.
Yeah.
So that's the truth.
Yeah, yes, I like the nurses. They are open-minded. There are some nurses that I know for years and some that I don't see anymore, all the time. But I like the nurses in Mount Sinai, yes.
Yeah. By the way, I tell them the same thing. It's important to know what to advocate for. I tell them normally I do delayed cord clamping for usually around a minute unless I have to do a C-section because they're bleeding. Fine, I'll do it 30 seconds. If you want to do it more, well, let us know.
Yeah.
We try to get skin to skin on all the moms unless they specifically tell me not to because sometimes they're like, it's icky, clean the baby first. Fine. That rarely happens anymore. Yeah. But it's important to know what to advocate for, and also as a doula, you are their advocate when they're in pain. If when they're on another planet somewhere, you and their partner are the people advocating for what they want and their preferences. You're their healthcare liaison.
Yes.
So
that's our job. We are kind of translators also, not from English to English or English to Spanish, but
from feelings to words.
Yeah, and also what the doctor is saying and what that means
Yes.
in this precise moment. Because I don't know, rupturing the bag of water is not the same 3 centimeters, 7 centimeters, or 10 centimeters.
And there's some things that are medically necessary, and then there's some things that are not. Like I'll tell patients, hey, I would like to, especially if they have to be induced for whatever reason, I would like to break your water. This is what it means. Do I need to break their water now? No. What are the advantages and disadvantages? Advantage is it's about 5 hours faster, and when you have a Pitocin drip for whatever reason, and you may want it faster, but then there's always trade-offs.
Exactly. So,
but it's important, like you're saying, that the patient knows what that means and what their options are.
And she chooses the option.
Yes.
Now, if she doesn't know the options, she's not choosing.
Correct.
She's doing whatever the doctor, the mother, whoever is that, the doula is telling them.
Yeah.
So,
and we do our best to explain it, but you know what happens all the time? I explain, I'll even sit there sometimes, 30 minutes, I'll walk out of the room, and the patient's like, what did they say? Because people need time to process.
We are there to translate that.
Exactly. So let's
remind them, yes. So it's important to have a doula. This is what you are saying.
Yes. Okay. So I usually tell people in general, if they want an unmedicated birth, you need a doula. You need a coach. You need someone to get you there on time, and your chance of success is a lot higher. And I usually ask, I point out the partner, how many births have they gone to? And it's usually their first as well. They go, none. So I'm like, you're going to trust this guy? And I'm like, how many births have you been to?
But I need to say, not because, again, I'm not advertising doulas, but I do need to say that even if they do prefer to get in some point an epidural, they still need a doula.
So explain that to me.
Okay.
I want patients to hear that.
Okay, so first of all, as a doula, I will suggest she tries to progress the more she can. Mm-hmm. Getting the epidural, let's say 5 centimeters, 6 centimeters. Starting active labor with an epidural rather than nothing, or 2-3 centimeters. So somebody needs to, mm-hmm. I go to their place, let's say they call me, hey, I'm in labor. Okay, surges are X. When they're 5 minutes apart, I come to your place.
Sorry to cut you off, but it's just where we practice, by the way, in Miami, where epidurals are really easily accessible. There's parts of this country that if you were not 6 centimeters, they won't even let you on the labor floor.
I know.
So my point is
I know.
This is a Miami problem.
Absolutely.
Specifically.
That's correct.
And then there everyone needs a doula, or they need to figure it out because they're getting to 6 centimeters without an epidural.
So here you can, so we go to the hospital together when she's 3 minutes apart.
The contractions.
So who is taking care of it?
Yeah.
The doula. Answering questions, supporting her until she's ready to get the epidural, sorry. She needs a doula. Now she is laying down on the bed with epidural, saying that everything is perfect.
Mm-hmm.
Sometimes it's not.
Sometimes it's not. A lot of times it's not.
Yeah.
And another thing what you're saying there too is beforehand, and you see there's a huge difference in family structure. And everyone had home births before there was doctors. Who was there? Their moms, their sisters,
the neighbor.
They had the support.
Exactly.
They had people who went through it with them.
And by the way, they were less afraid.
Yes, because, well, there was also no options. So sometimes more information is harmful.
Yeah.
So,
yes.
But they had that support of people and of a community. And I say the same thing afterwards. My patients have the ability to get a night nurse. I tell them to get a night nurse, or a postpartum doula, because one of the downsides to the changes in society is that there's no support at home. And it is so needed.
New families absolutely. So now she's on the bed. Let's say she's smiling, everything. We need that baby to calm down, mm-hmm. right? We need things to keep happening. So the doula will be doing the rollover from one side to the other. It is right that the nurses are doing that, mm-hmm. but the nurses are busy with other things, with other patients. Mm-hmm. The doula is there.
Okay. They're in, they're out, and not all nurses, same thing with not all doulas are created equal. So if you have the ability to hand select your doula, that is incredible.
Now, if she needs to keep breathing, mm-hmm. because the fact that she's having an epidural doesn't mean she's not in labor. She's still in labor. She needs to breathe. She needs to keep connecting with the baby. How about the picture of, okay, she's having the epidural, so now I can sleep, now I can go and eat, now we can turn on the TV, now we can see who is chatting with whom. No, you're in labor, you're having a baby, you're welcoming a baby, so be with your baby. Mm-hmm. So the doula is I do believe, very important. By the way, after an epidural, maximum next day, I'm going to my chiropractor. Because
you're all misaligned, yeah.
Yes.
No, that's very true. And there's different things. One of the most beautiful things of the unmedicated birth is that rush of oxytocin and adrenaline that the mom gets. And there's something about being able to stay there and connecting, with or without. And when you do have an epidural, some people naturally connect. Some people need to be reminded, because sometimes there's a little bit of a dissociative experience.
Exactly.
So
Mm-hmm.
to keep someone engaged, to tell the dad to turn the football game off.
Yeah.
And
yes.
to be there.
Yes to that.
Good. Look, I think this is an amazing conversation. You did mention something called the rollover.
Yes.
Do you want to show me
Absolutely.
that before we go?
Yeah. So let's imagine this is the uterus. Can we?
Yeah, let's do it.
And this is the cervix.
Yes.
Okay, so this is let's say 38, 7 weeks pregnant. We can see some.
Fingertip.
Yeah. Good. But after some time, it goes to 50% the face, and we can say almost 1.5, maybe a little less.
One, yeah.
Okay.
My finger, I've gained a little weight, so my finger's a little thicker.
Now, she's in labor. Things are happening.
Yeah.
So I will say 80% the face, kind of.
Sure. Yeah.
Okay, and
about 4 to 5 centimeters on the outside, 5. Yeah.
And we could see the kind of the head of the baby over
Oh, look at that! Look, there's hair, guys.
And then she's breathing, and she's a champ. 90% the face, and 6 to 7 centimeters dilated.
Yeah, look at that. Yeah.
And then she's almost done.
Yeah,
100%, 10 centimeters. She will start feeling the natural expulsive reflex.
I will tell you this though.
What?
I don't think this head is fitting through there. I have to make you laugh a little bit. But
yeah, you like it?
Yes.
So this is a board doula during COVID.
I love it.
Yeah.
I love it. Well, that's actually something we didn't talk about before. How do you coach them to push? What do you do with the surges when they start feeling the reflex?
So I tell them, even though sometimes it's against what the doctor and the nurse is telling them, I tell them, listen to your body.
So if they don't have I've had to stop nurses because if they don't have an epidural and they're feeling that, they feel their tissue stretching. So they will automatically push and stop themselves.
Okay.
On the other hand, when I'm there watching, it's because some people lose that control and they push too hard too quickly.
Yeah.
Which is different.
But the thing is, usually they will push hard many times when somebody's telling them to push.
Yes, but that's why I tell them, don't push. So I agree with you. I'll tell them, listen to your body. Sometimes they'll ask for some advice, and I'll tell them, you know what, maybe pull your legs closer to your chest, open up the pelvis.
Yeah.
Okay, if you're side laying, don't lie like flat. Like right now, the way we're both sitting is our hips are pretty open.
Yeah.
Because we have a good positioning.
Yeah.
So sometimes I'll give them that advice. When they have a epidural, the issue is they lose that reflex.
They don't feel it.
So then
they don't feel the urge to push.
So then I have to teach them to close blow push.
But the last birth we had together, remember? She had an epidural. She felt the pressure. She didn't feel the urge to push, but she felt the pressure. And the baby
just came.
You just...
Correct. And that's something I was going to say is when they do it, my job is, on the other hand, I need to get them to push hard to get that baby to restitute. But once what happens when they're doing the last cardinal movement and the head is extending, you can take a step back. You want that to happen slower. You want to allow, assuming if the baby's doing fine, you need to allow the baby to just come.
Exactly. To expand and
And I really think that makes a difference with tearing because the tissue has a chance to prepare itself.
Absolutely. I do believe that during the regular, 100% of the world, of the Occidental world is push like crazy, counting to 10.
I had a attending in residency. No, pare, sigue. Yeah.
Sometimes I tell my clients' husbands, they are my clients too, this is not a football game. So relax. You don't have to count together with them.
Yeah, and faster is not always better.
That's correct. Yeah. Good.
So good.
I'm happy you like
this
it.
This is fun. So you were telling me something about the rollover for people who do have epidural.
So, you want to be the pregnant woman?
Yes. Let me just take these shoes off. We'll see how the audio comes out with this. I can actually fix it, which is kind of cool.
Okay.
But
so let's say you have the epidural.
So I'll do what they standard do.
We don't like that.
I know.
You
have to fix it.
No. Okay. So, oh my God. It's very hard because you know how many cables you are connected right now?
At least 3 to 4.
No, you are connected with almost 7, 8.
7, 8.
Yes.
1 monitor, 2 monitors, an IV.
The
pulse ox, it's 4.
Yeah, the epidural.
Oh,
the catheter.
6. Yeah, you're right.
So
you're stuck everywhere. You're being probed out of everything.
So, may I touch you?
Yes.
Okay.
Right.
So, with this hand, take the rail there and just a minute.
I'm sorry, I can't do that fast.
So I was good. Thank you for moving your leg.
My epidural didn't work very well.
Poor thing. So you can rest. Okay, this is one position. When you are here.
And what are we trying to accomplish with these positions? Oh, pelvis. Great.
Yeah. So what we want actually is to make the pelvis change, the shape, the opening, so your baby can keep turning and descending and doing the work. So let's say your pelvis right now is like this. Okay, with your leg up, maybe a little.
Just for the camera.
Okay, maybe a little like this. Okay, because thanks to relaxing, this is moving all the time, right? 30 minutes like that. Then I will come.
This is called the rollover technique, right?
Yes, the rollover. This is Penny Simpkins, the mother of all doulas. Now I need you to straighten this leg. That's right. And I will bring this here. Can you bring your shoulder to be on the bed? Let's say this. Perfect. So now we are not only changing the shape of your pelvis. Let me show you. Now from here your pelvis did this and it's opening, but also your baby is getting some pressure from the bed, so helping the baby going down. Another 30 minutes. After that I will say, okay, let's put it here. Try to roll to the back. I'm happy this is not the same.
Grab the rail.
Exactly. Go to the other side. Bend your knee here. Like this. Now we are in the other side. 30 minutes. After the 30 minutes, I will come. I will move. I will ask you to put the leg straight. Perfect. Usually, you see why you need a doula?
And I see why you need your chiropractor.
That's right. 30 minutes. Now, there is a variation that we can do thanks to the amazing beds we have in the hospitals. You can come here, go to your back, and I will touch the buttons so you can up, legs down.
Now I'm doing boat posing.
But you can do that. And that's it. And then we start again.
And that helps the baby descend down.
Exactly. We need the baby to move down. Now, if the baby is not moving, we need to move the mother.
Okay.
Right? Baby's not moving, move the mother.
That works.
And it works. And it works.
Yeah.
Now, I saw some nurses using the, what's the name?
The stirrup.
Putting the leg. It's also an option. I like the birthing ball. This is the side I like. I don't like the really huge ones.
The ones we have are longer.
Yeah. Now, a little anecdote. I came to with this ball to Mount Sinai 12 years ago after I took a course. I entered like this and my thing, and one of the nurses there that we are very friendly, she said, I think she's not there anymore. Adriana.
I think she's still there.
No, the tall Adriana.
Oh, no,
she's not there many years.
There's a new one.
Yeah. So she's like, what are you bringing us now? And now every hospital
has them.
So we do our changes. Yes.
They got new beds, which are nice.
They're amazing.
But the thing that they don't have that I wish that they had was the squat stands. They don't have them anymore.
The bar?
Yeah.
Oh.
Yeah, I miss that.
But we can do the rebozo.
Yeah.
Like.
Yeah. But what I liked about it, I don't like to call myself lazy. I'll call myself energy efficient. Is I used to have them do it with the squat stand, and no one fell over.
I will call you a very respectful of the physiology of birth person, more than lazy or whatever.
Thank you.
Yeah. Yes.
Oh, good.
So this is the rollover.
Amazing. I love it. We'll have to do it.
Good. Is the baby coming down?
I think so. I think it's still ROT, but I think if I spend 30 more minutes, we'll get there.
Sometimes this takes hours.
Yes.
But you know, there is absolutely nothing more to do.
Yeah. Well, I'm not going to have them do lunges when they have an epidural in their back.
What about some walking epidural?
I don't know any hospital. Do you know any hospital down here that has them?
Orlando.
No.
Not here.
That's interesting. I didn't know anyone in the States was doing that, mostly for liability purposes.
Okay.
If they gave you too strong of an epidural, people will fall down.
Yeah.
So at least I don't know anywhere down here. That's interesting. I'm assuming it's Orlando Health.
Yes.
Yeah, they do.
Yes.
That is a beautiful hospital.
Amazing hospital.
Beautiful hospital.
Yes, they do everything. They do. I think they came together with a kind of hospital birthing center. You know, very.
And they have that model in the Northeast, and that was actually my dad's dream to create something like that.
Okay.
I gave up on that dream. Why?
Really?
I have no control over the hospital, but I can control what happens in my office and outpatient.
Yeah.
So I feel like I'd rather control what I can control. Notice Mount Sinai, the nurses are great, everyone is great, but it looks exactly the same as 50 years ago. So
yes. That AC, come on, change this. Yes, but you know, the truth is, of the records again.
We're on recording, by the way.
Yeah. Okay.
Okay.
No, because I don't want to sound like I'm advertising you guys.
Yeah.
I do recommend you all the time, of course, but I don't get tired enough to tell women and couples. You know, we are looking for a car, right? And we take all Sunday. And we go to Mitsubishi and Hyundai and Mercedes and we tried the car. And then after hours and hours, we buy a car.
Yes.
With the OB-GYN, we go to the first one, we don't ask, and that's a mistake. And I wish I could get to, you know, not only your patients, but everybody. They need to change that. They need to look for the person who is aligned with their own desires.
I 100% agree. And that's part of the reason why we're making this video. And it's not to get more patients. You know, we have way too many patients.
Yeah.
But there's also, by the way, there's a lot of very good doctors out here that...
Absolutely.
Exactly. And I think it's worth putting in that extra time. And also, I think I would encourage other people to make videos like this so when patients are looking, they see who you are before they show up, so they're not wasting your time or anyone else's time. It's specifically theirs.
Idea. It's a great
so
idea.
they can find a good match. It's beautiful. Some patients like to be told what to do. We talked about a 39-week induction and why I offered it, and you're like, why would you do that? I think it's right for some people. It's not right for other people. But that is their choice. There's always the patient's choice. And that they just need to be given the information.
But patients don't know that.
Yes. Our patients do.
Exactly. So back to the 39 weeks, there is a difference between you saying this is what I recommend in your situation, but it's your choice, rather than 39 weeks, that's the deal, and if not, your baby, blah, 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 blah.
So we do have a stronger pull. Sometimes I'll say we need to have a 39-week. If a mom's blood pressure is 150 over 90,
of course.
If they're diabetic and uncontrolled,
absolutely.
If they're first baby IVF and they're 45 with donor eggs,
I cannot agree more. But
yes,
if she's healthy, if the baby's healthy, if pregnancy was healthy,
then it's their choice until proven otherwise, and then it's still their choice,
Exactly.
But we will make a stronger recommendation.
Exactly. But they need to know that
they have them. Yes.
Yes, that's important. That's important. Sometimes some people will feel that they don't have the option to say no, or the option of asking questions.
Yeah,
that's true. Yeah.
Thank you guys for watching. This was a lovely interview with Diana. If you like this and would like more videos similar, please like and subscribe, and we'll see you in the next one.